Good morning. My name is Dr. Stephen Sanet. I'm an American osteopathic physician, and I'm going to talk to you today about mechanisms of head trauma, head injury. Okay, I want to have a little bit of fun today. This is kind of a fun lecture. I want to talk about head trauma, vectors of force, and it's the understanding of how the head trauma and forces pass through the skull rather than particularly the modalities that we're going to do to it. So this is really going to touch on a fair bit of physics and anatomy. So this really reduces us to Newton's laws of motion and how things are affected. So if we look at Newton's second law, which is that the momentum P is going to be equal to the mass times the velocity. And I have this little example here of the billiard table that many of us are familiar with. The cue ball hits the other balls and it transfers the force. So in any sort of trauma, be it head trauma or other type of trauma, and we can even extend this to emotional trauma, forces are transferred, and then it's what happens with that force after it's transferred. So I'm going to look at some physical examples of that, and then we'll relate this to cranial examples. I pulled out these old photos, kind of fun photos from some demonstrations in the vaudeville era and things that we see today, showing people lying on a bed of nails and tremendous pressure being applied to them. These are a little bit of tricks, not meaning that there isn't some skill uh, required for this, but they're a bit of a trick in the fact that to lay on a bed of 1,000 nails is not really so difficult. To lay on a bed of 3 nails, well, that would be impossible. That would just pierce your skin. So there's some things that we have to take into account when we talk about forces, and that is the susceptibility of the tissue to damage. What type of tissue is it? What is the overall impulse being applied? And over how big an area is that applied? If it's a very large area, like your entire body laying on 1,000 nails, the actual force per small unit of area is very small. So it's the force that's applied, it's the type of tissue it's being applied to, and it's the ability of that tissue to transfer that force that becomes very significant. Another real life example, and one from my own past, from my martial arts past, is we've all seen these tremendous demonstrations of breaking bricks and so forth. And again, there is a skill to doing that, and there's a bit of trickery to that as well. This is really Newton's third law in action. So, Newton's third law says that each force has an equal and opposite force, or each reaction has an equal and opposite reaction. I step on the ground comes up and hits my foot, and we can relate that to back pain. In the martial arts example, you hit the brick is hitting you, but there's a difference what happens with the brick hitting you versus you hitting the brick. You hitting the brick cannot transfer any of these forces. And so if you've done this correctly, the brick will break or whatever structure is going to receive a lot of pressure and it can't transmit that force. Whereas your hand, that force is going to, I'm going to give you an example of what happens with that force. The force is going to go into the body. When I was a youngster, when I started martial arts, I was 12 years old. And we were given very cryptic, mystical explanations for how and why to punch. And we were told with a correct punch, I should hit with these two knuckles in your basic martial arts punch. And we were told that the reason why this is the correct way is because those knuckles are bigger and that's why it's going to do damage. And that's actually not the correct answer at all. It has to do with the alignment of the hand. So that if I strike something with these two knuckles, the alignment of my hand is such that this force is going to go um, through essentially scaphoid into the radius, and the force is going to get out of the hand. The force is going to come in through here into my radius. From my radius, we're going to try and transfer it to an even larger area, to my humerus. Well, in order to do that, the radius is articulating with the scaphoid, but the radius does not articulate, does not transfer forces to the humerus. It's the ulna that is articulating with the humerus. So how do we get the forces from radius to ulna? A bit of a dilemma. Well, that's happening through the interosseous membrane. The interosseous membrane is a reciprocal tension membrane. When the forces are applied here, the attachments between these two bones pulls the ulnar bone and it transfers the force into the humerus and then into the body. And so that force going into the brick cannot dissipate the force, and yet the martial artist is able to dissipate that force through their entire body, or at the very least, able to dissipate it from these small breakable bones through bigger bones, through the humerus, and very likely into the shoulder. And that's why there's no damage. In the example of a boxer's fracture, um, this is the type of thing where I'm just showing the forces coming in from these knuckles. Were you to strike someone essentially with these two knuckles, it's a different force vector. So these forces are essentially coming in towards the hamate, the pisiform, the triquetrum, and they're directing themselves toward the lunate bone. The problem with that is there's no articulation with the ulna in the wrist. The articulation is with the radius. So those forces have to go somewhere else. And that somewhere else can relate in carpal fractures, phalange fractures, anywhere else, because they can't take that kind of pressure. So I'm trying to tie these ideas together with there's the force applied over an area. How much damage can that particular area sustain? There's the force itself, and then there's the uh, ability of that impulse to pass out of that area. If it can pass completely out of that area, then you're left with no damage. I tied this in together with just a few ideas from Beryl Arbuckle, because Beryl Arbuckle was doing work in the 1940s, 50s, and 60s with cerebral palsy children. And she was trying to theorize how traumatic births resulted in what she saw as cerebral palsy. So she did various dissections um, here, dissecting out the squama or the flat portions of the bones. And she theorized that these were the vectors along which the forces were passed. And she was trying to understand what went wrong during various traumatic births that sustained the force on the child. Tied in with that is our dura, which is a reciprocal tension membrane. Okay, we have reciprocal tension membrane between your interosseous membrane, between your tibia and fibula, between your ulna and radius. This is another reciprocal tension membrane here. So this has to balance pressures all throughout the skull. Some other considerations for trauma to the skull are sutures and vectors of forces. So we have various things to try and protect our brain from trauma. We take a blunt force trauma. It's not the same should you get hit everywhere in the head with a certain amount of force. First, the CSF is acting as a shock absorber. The brain is floating in plus or minus 120 to 150 cc's of fluid. That acts as a shock absorber. The dura is going to transfer those forces so that it's not sustained in a finite area, and hopefully transfer them to a larger area, perhaps down the neck. There is a difference in how the orientation of the sutures also allows protection. And you can't really see it close enough on this diagram. You'd have to look at this articulated skull. But should we strike something along the squamosal suture, the coronal suture, there is the ability of those sutures to buckle. Again, I'm giving you a perfect situation and saying a certain force at a certain velocity might result in this. That same force applied to the lambda area, you don't have that buckling. You're going to have more of an implosion. And it has to do with the nature of how the sutures are coming together. So the deformation here, if you were to get hit straight on the back of your head, this is really imploding. It's got nowhere to go. In a similar situation, applying force to these other sutures, they can buckle and bend outward and pass forces, perhaps around the skull, perhaps down the neck, perhaps into a larger area. So these are things that need to be considered. The other thing that it needs to be considered with brain injury is what part of the brain gets damaged. there's actually a lot of the parts of the brain where the damage can be relatively small, even with a massive traumatic effect. What part is actually is struck? And I've just pulled out some outrageous examples. Um, One was this is 2007. There was a sheriff's deputy in Wisconsin, killed his girlfriend, killed a bunch of people at a house party, and then fled the police. When he got caught, he took his 40 caliber Glock, which is a um, significant type of pistol as far as stopping power, and tried to commit suicide. He shot himself twice under the chin and then once in the right side of the head, and then he died from that third shot. What is what is amazing is that he shot himself under the chin, survived it in that moment, was able to have all the muscular control to shoot himself again under the chin, survived that, and then no doubt did some damage to the brainstem and then successfully killed himself. Another very famous case, and we could do many of these, but this is one that's pretty well known, at least in the West, was Phineas Gage. Phineas Gage, you can see him there on the right, holding the railroad spike that went through his skull. And this is how it went through his skull. Okay, it took out his eye, a huge portion of his brain. And this guy, by all accounts, his memory and his intelligence was relatively unimpaired. He had left frontal lobe damage, which they say manifested as an irritable personality. And I think it's kind of interesting. I guess a spike through your head, you surviving it, you might not be the most pleasant person to hang around. But other than that, he lived out his life. And there's many other such cases like this. So it's not just the trauma. No two traumas are exactly alike, and we can't just decide, well, this hit you on this side of your head, so you're going to have this type of problem. I don't approach things that way osteopathically. Osteopathically, I look for what I feel is restricted in the body, and those of you who know me know that that is my chosen method. So if you say I have headaches, yes, I'm going to find things locally on your head that I can treat and try and address the symptoms. But I'm going to globally say, where is that trauma in the body? Where is the point at which it couldn't move any further through the body and it's stuck here? We can apply that same idea of a vector of emotion through the body. Where does it get stuck? And for myself, I'm not differentiating between emotionally stuck and physically stuck. I'm just trying to find it by global diagnosis where I feel the restriction in the body. I don't actually differentiate between the energetic and the physiologic. Not in my global assessment. Locally, yes, I'll try and differentiate it. So that's my approach to things. Thank you for your attention. And if you like what we're doing, please subscribe.